welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Happy Monday, friends! Welcome to Brain Chat. I'm Dr. Mitzi, your board-certified neurologist, MS specialist, and I am so excited to be back with you for another episode of Brain Chat, where we will be discussing tonight a disease that's very similar to MS, but distinct, called Neuromyelitis Optica. Say that 3 times fast. Neuromyelitis Optica. First, we want to thank our sponsor, Janssen, for supporting Brain Chat with the Nerdy Neurologist, and you can learn more about them by visiting moretoms.com. And you all know, as we always do, please feel free to put in the chat where you are viewing us from. I bid you greetings from the sunny and 83-degree weather in Atlanta, Georgia. So it is hot here in the South, and I hope that you all are enjoying some of the spring weather. But yeah, go ahead and feel free to put in the chat where you're logging in from. I'd love to hear where you guys are viewing us from. So tonight, we are going to get right into this amazing action-packed episode. I am so excited to have my good friend and colleague, Dr. Kottil Rammohan, with me tonight to discuss NMOSD. And I am going to read you a bit of his impressive bio. He is a clinical professor of neurology and the director of the Multiple Sclerosis Center at the University of Miami in Miami, Florida. He's board certified by the American Board of Internal Medicine, as well as the American Board of Psychiatry and Neurology with special competence in neurology. His credentials are unmatched, and he has trained in multiple places, including Cook County Hospital in Chicago. He did medical college in India, and he was a fellow and senior clinical associate at the National Institutes of Health, where he trained in neurovirology and neuroimmunology. He is a master clinical trialist and has done many trials, and his research is actually focused on fatigue, a symptom that we may get into a little bit tonight, but certainly we've got some symptom management series later on in the season where we may have him come back and tell us a little bit more about that. He has been involved and served on the National Multiple Sclerosis Society as a member of the Medical Advisory Board and Clinical Care Committee, and he has recently been recognized as the Researcher of the Year for 2019 for his vision in starting the database NARCRMS, which we may also get into a little bit of tonight. So let me bring Dr. Rammohan up to the stream. Hi, Dr. Rammohan.
Good evening, Mitzi. It's a pleasure to be here, and thank you for doing this for everybody.
Absolutely. Absolutely. So, I really love to bring awareness to different topics. I love to empower people, right, with knowledge, because I think it's so important. Some people have access to us, right? People who are specialists, who have a special interest in multiple sclerosis, neuromyelitis optica. But for some people, they don't have access to that specialist. So some of the way that they can empower themselves is to get the knowledge for themselves and kind of take that back to their doctors, or, make sure that they're connecting with specialists who understand their condition. So how did you, and I ask this of every guest that comes on our show, how did you get into this field of neuroimmunology, multiple sclerosis? Because when I started, fellowships were just kind of coming around, and those who were training us, just happened to, have that passion and take that special interest to really create this field.
So I always knew that I wanted to be a neurologist. So that was something that I had known right from medical school. I was attracted to the brain at a very, very early stage in my career. And I also wanted to do internal medicine because, when you come from India, in India, you do not become a specialist before you first become an internist. So I knew coming here from India, and I came in 1970, a long time ago. And, when I came, I knew that I was first going to train in internal medicine. And then I was going to train in neurology. So even when I was interviewing for internal medicine, I interviewed for neurology. And I finished the traditional 3 years of residency, following following not just a year of internship, but a whole residency in neurology. And I was going to be a general neurologist, except when I attended the American Academy of Neurology meeting. That time it was in Bar Harbor in Florida, Bal Harbor. And I took the neuroimmunology course, and I was fascinated with what I heard. And I went back to my chairman and I said, I'm not going to come on as faculty as I thought I was going to do. I'm going to do a fellowship. So the disease that I wanted to work with was myasthenia gravis, because it was so exciting. There was tremendous progress that was being made. And the person who gave that course in the academy was Dale McFarland, that unfortunately passed away at a very young age. And I met with him, and he was at that time in Emory and was going to start the neuroimmunology branch at the National Institute of Health. So I interviewed with him. I was his first fellow. Dale McFarland and Henry McFarland, and everybody knows Henry because he's an icon. And the two of them started the neuroimmunology laboratory, and I was their first fellow. And that laboratory has trained such a large number of people in the MS field. It's almost like the mothership. And so it was not really with any person that I knew that had MS that I went into MS. It was just the fascination to neurology, the fascination to immunology. And of course, when you work with multiple sclerosis, you have to work with immunology. And I also worked with virology, because the prevailing thinking at that time was that MS may be caused by measles. And so I spent 6 years of my life dissecting the measles virus from stem to stern. And of course, made monoclonal antibodies to measles virus and the whole 9 yards. But of course, that is not what we think is causing MS today. But that's in a nutshell my story of how I got into MS. And I must say that I have thanked every day of working in this field. It is so gratifying to take care of people who have this unfortunate disorder. And we made great strides, as you know, from the days when I was doing my fellowship, when we had nothing. We came to beta-seron, our first disease-modifying therapy, and now a whole host of drugs. And of course, we have since then branched off this disease that we thought was a type of MS that we now know is not a type of MS, but a disease in its own right. And that is neuromyelitis optica spectrum disorder.
Yeah. I mean, such an amazing story. And thank you for learning about the measles so that I didn't have to. So I appreciate you figuring that out before I came to the field.
That did give me a very good grounding in virology that I find useful today in understanding COVID, the vaccinations, and all the details about the nitty-gritty about the virus.
Absolutely. And, the thing that really attracted me to neuroimmunology is just, I always felt like it was kind of, I won't say the final frontier, but I love the fact that everything wasn't figured out, that there was room for discovery, that we have some therapies, but that, there was the potential to find bigger and better ways to treat our patients, but also potentially ways to figure out more about how the disease comes, the etiology, the risk factors, all of those things. I love the fact that it wasn't figured out to the very smallest detail, and that was one of the things that really attracted me to the field
always
of MS.
A better way to build a better mousetrap. Yes,
absolutely. I'm up for a challenge. So you alluded to what we're going to talk tonight, which is NMOSD. So, let's kind of talk about the history of how this condition was thought to be a part of MS. So, de Vic's disease or neuromyelitis optica, now neuromyelitis optica spectrum disorder, our understanding of it really has evolved. And I think it's really fascinating, kind of the story behind how we realized, that it wasn't a part of MS, that it was distinct. So, can you start us off by kind of talking a little bit about that evolution of our understanding of it being a distinct disease from MS?
Absolutely. So actually, if you look at from a historical standpoint, NMOSD, then known as Devick's disease, actually, Devick described it around the same time as Charcot described MS. The two were really contemporaries, and Charcot in France uh, described multiple sclerosis, and Devick described the disorder that he actually called it neuromyelitis optica. That's a term that he used, but because he described it, it became synonymous with his name, and lots of people would call it as Devick's disease. Yeah, and it was known as Devick's or neuromyelitis optica. And what he described was something similar but different from multiple sclerosis. These patients developed devastating onset of optic neuritis. And we are not talking about gradual loss of vision in one eye followed by recovery. We are talking about sometimes bilateral optic neuritis, sometimes occurring at the same time, that leaves the person permanently blind. And he described this entity within 6 months of onset of the optic neuritis. The person will go on to develop a transverse myelitis that would either make the person paraplegic or quadriplegic. So here is somebody who is blind and immobile, and obviously resulted in a short lifespan because of all the complications that one would go through with decreased mobility. And that combination of involvement of the optic nerve followed by the transverse myelitis was the entity that was called as Devick's disease. In those days, one of the requirements was that the brain was free of lesions. In fact, that was one of the original criteria for diagnosis of neuromyelitis optica, that you had involvement of the optic nerve and spinal cord without involvement of the brain. But now we know that's not entirely true. We can have brain lesions, but they're different brain lesions than what one is accustomed to seeing in multiple sclerosis. Even though brain is involved, they're completely different looking lesions on MRI. So that was the original thing. And of course, if you look at it, the original Devick's disease of just optic neuritis and transverse myelitis, meaning blindness and motor impairment, which is what the transverse myelitis meant. Basically, it was not just a little bit of sensory loss. These are people with devastating involvement of the spinal cord. That combination was relatively rare. So for the longest time, we thought that this was an esoteric disease, and some people would never see it through their career, and others would see one or two of these cases in the description that Devick had. But the greatest advancement in the field was the discovery of the antibody. So Vanda Lennon from the Mayo Clinic, she is just a tremendous scientist. She has discovered so many things. She was married to Lambert, Ed Lambert of the Lambert-Eaton myasthenic syndrome. And so she's also the one who discovered the source of the antibody, or the target of the antibody for Lambert-Eaton myasthenic syndrome. So she has made many, many contributions. And one of her contributions was to take the blood from a patient that had Devick's disease, and she put it on a mouse brain, and she could show the presence of fluorescence of the capillaries and the blood vessels. So she knew that it was staining the vasculature in that location. And then she looked at the components of the blood-brain barrier and looked at systematically one by one, and found that these antibodies reacted specifically to a protein on the astrocyte foot process that goes to form the blood-brain barrier.
Mm-hmm.
And that protein on the astrocyte was a water channel. And that water channel, there are 13 different types of water channels in the mammalian brain, in the mammalian body. And this one was aquaporin 4.
Mm-hmm.
Aqua meaning water, pore, the pore for water, the aquapore for water that is present in the brain, actually the fourth type of the channel that is described. As the discovery of the water channel got the Nobel Prize. It is such an
Mm-hmm.
important discovery.
Right.
And she identified very clearly that if you take the water channel gene and transfect Chinese hamster ovary cell lines, and now these cell lines are expressing the water channel 4 on their surface. And if you take the blood from a patient with neuromyelitis optica, and lo and behold, that lights up. And it
Mm-hmm.
really, and even to this day, the cell-based assay that we use is that assay where
Mm-hmm.
you have a cell line that is expressing this water channel, and you go and treat that with the patient's serum and wash that, and then you stain it with anti-human IgG, and beautifully it lights up,
Mm-hmm.
indicating that this person has an antibody to the water channel. So
Right.
essentially, all of a sudden, we now have a biomarker. That
Mm-hmm. And what's a biomarker?
a biomarker is an entity. It can be a lipid, it can be a protein, it can be an antibody, it can be any biological entity that is a marker for something. And in this case, it is a marker for this disease. So
Mm-hmm.
you can have neurofilament light chain. Neurofilament light chain is a marker for it comes from the axons, and so it's axonal injury that occurs, and it is because of inflammation that occurs in the brain. So it's a marker for inflammatory component in the brain that leads to destruction of axons. So
Yeah.
these are markers, and we are always looking for markers because you want
Yes.
the marker as a surrogate for something, and that
Right.
allows us. So basically, antibody to aquaporin 4 became a marker for this disorder. And lo and behold, from a rare disorder, it became a more common disorder, not a very common disorder, but a more
Mhm.
common disorder than we previously thought.
Right. Right.
Yeah.
So so you said so much. I feel like we're getting like an amazing history lesson here. But there's so much that you said. Let's go back just a little bit to when you were talking about the symptoms, right? So one of the distinctions between MS and neuromyelitis optica is that when people have relapses, right, or new symptoms such as the optic neuritis, it can often be very devastating, right, with poor recovery. For instance, I had a patient that I saw recently who was in her 20s that went blind within 6 months, right? So, I mean, it was almost before you could get it diagnosed, she had already gone blind. And so, the optic neuritis itself, is damage to the optic nerves, but the symptoms can be very devastating, which is why it's so imperative that we get people diagnosed early and we get them treated early to try to prevent these relapses. Now, you talked a little bit about transverse myelitis, right, which can cause motor impairment. Let's talk about what is transverse myelitis, right? Because transverse myelitis can occur in MS, it can occur in NMOSD, it can also be idiopathic, right? Where people don't maybe have a larger disease at play. What is transverse myelitis and what are some of the symptoms of it?
So the term transverse myelitis is a descriptive entity.
Mm-hmm.
So
Mm-hmm.
myelitis means inflammation of the spinal cord, and transverse meaning it is at a certain level
Mm-hmm.
in the spinal cord that it occurs. So when you say a patient has transverse myelitis, even though it is a diagnosis, it is not a diagnosis.
Right.
It is diagnosis to a point that it localizes the problem to the spinal cord. And when I hear that somebody has transverse myelitis, I have this mental vision of somebody having difficulties that affect a certain level of the spinal cord, which means that below that level, some function is impaired. You mentioned that it occurs in MS, and that's absolutely correct. You do have transverse myelitis. That's part and parcel of the symptoms that a patient with MS can go through. But the distinction between the transverse myelitis of MS and neuromyelitis optica is in NMOSD, the transverse myelitis can be devastating. It doesn't have to be, but it can be devastating. And it is almost like a complete transection of the cord in its complete form, whereas where you below a certain level, you have no sensations, no motor function, loss of sphincter function, and total lack of mobility and everything else. So that is the complete transverse myelitis. And if I see a patient with complete transverse myelitis, almost like transection of the cord, MS is not the first thing that I would think of. NMO is the first thing that I think of. That's not to say that it doesn't occur in MS, but it is uncommon in MS. It is much more common to have a sensory myelopathy. So, for example, what a patient with MS will tell you is that my toes went numb, and 4 days later it was up to the ankle, and a week later it was to my knee, and now a month later it's up to my chest. And this is the ascending numbness that they experience. It reaches a certain level, and then it can be, when you image the patient, you see a lesion in the spinal cord, either in the neck or in the thoracic area. And this has a level below which symptoms occur. And that's usually the presentation in multiple sclerosis. Now, in neuromyelitis optica, it is usually not a slow marching thing. It is much more abrupt and much more complete, and it's much more devastating. It doesn't have to be. It can be confusing and look like MS, but it's not often the case. Often the case is in its full-fledged form. It is a complete transection at a certain level. And of course, because it is a devastating attack, it can actually have poor recovery, just like the optic neuritis, which occurs in both eyes, also can be left with poor recovery or partial recovery. Patient can be completely blind or partially blind. In this case, patient can be partially impaired or completely impaired, depending upon the degree to which it occurs. And the other thing that is to be kept in mind is, when you look at the lesion in multiple sclerosis, it's usually localized to one level. In neuromyelitis optica, it is across multiple levels. And this the term that is used is longitudinally extensive transverse myelitis, or longitudinally extended transverse myelitis. And at least 3 levels can be affected. And when you see this type of a presentation, longitudinally extensive transverse myelitis, almost certainly that is not multiple sclerosis. It is almost certainly something like NMO. There are other conditions that do that as well, but NMO is number 1, 2, and 3 diagnosis that you have to think of.
Yeah, and when we say longitudinally extensive and when we talk about levels, when we think about kind of the way our spinal cord is broken up, let's say anatomically, we have our cervical spine, which is in our neck, we have our thoracic, which is in the middle, we have our lumbar spine, which is kind of, the low back area. And so when we are trying to categorize where certain damage is, it's broken down into certain levels where the bones are. So there might be C1 through C7 and T1 through T12. And so when we say multiple levels, we mean over several of those spaces. So they're actually long, the lesions, when we look at them on the MRIs. And so, thinking about kind of diagnosis, right? We talked about longitudinally extensive lesions or long lesions in the spinal cord. What are the ways that we distinguish the diagnosis of MS from NMOSD? We've talked about a lot of it, but let's kind of, zero in on that. So we talked about, that people may have more severe optic neuritis. It can be both eyes or bilateral. They can have severe transverse myelitis or complete transverse myelitis with poor recovery. How do we tell the difference, right? So let's say someone comes in with an optic neuritis that's severe in one eye. How do we tell that they have NMOSD versus MS?
So it is very important to have a high index of suspicion when someone comes with devastating optic neuritis, or even mild optic neuritis, because of course the mild optic neuritis can start that way and become more devastating over time. So in patients that have optic neuritis, especially affecting the back of the optic nerve rather than the front of the optic nerve. In other words, the optic nerve that has gone towards the chiasm. In other words, as you know, the two optic nerves come together in the optic chiasm. If the lesion that you see in the MRI is more towards the back than the front, that is an ominous sign that this may not be MS optic neuritis. This may be related to NMO, and that the chiasm may become affected, in which case, of course, it's no longer one eye, it becomes both eyes. So, the location of the lesion is very important. And there's a lot of swelling that occurs as a consequence of the inflammation in the optic nerve. And that can translate to, when you look in the eye, edema of the nerve head, which is something that occurs. And of course, when you see that in both eyes, you know that this is a bad sign. And certainly in that patient, you should look for the aquaporin 4 antibody. And in the spinal cord, when you look at it, apart from the longitudinally extensive lesion that occurs in neuromyelitis optica, the other aspect that is important is that the lesion is central in the cord. It is not like what you see with MS, where the posterior columns are affected or the lateral columns are affected. This is a central lesion in the spinal cord. That's also the reason why the pain syndromes are much more common in neuromyelitis optica than in MS, because the pain fibers and the crossing of the pain fibers occur through the central part of the spinal cord. And so pain is, especially severe neuropathic pain, is very common, much more common, I would say, in neuromyelitis optica than with multiple sclerosis.
And so we talked about the MRIs, we talked about imaging. Now, the aquaporin 4 antibody test, or NMO antibody, what type of test is that? Is it a spinal fluid test? Is it a blood test? Explain what
You
type of
can,
test
yeah,
or how that's strong.
you can look at it in the spinal fluid, but I think it's the place where I would look at it first, of course, is the serum. And the serum,
Yes, the blood.
the
We
blood
want to
is
draw
where
your
it is.
blood before we do a spinal
Exactly.
test. Yeah,
Exactly. It can be seen in the spinal fluid, but the more important thing is in the serum. So draw a sample of blood and send it to a reputable laboratory. The Mayo Clinic lab is one of them. And of course, there are other laboratories that have picked up on the Mayo Clinic test, and they do it very similar to the way it is being done in the Mayo Clinic. And there are two broad categories in which you can look at it. You can look at it as an ELISA, meaning enzyme-linked immunosorbent assay. That is where you put the antibody in the bottom of a microtiter plate, and you overlay it with the patient's serum in various dilutions. And you actually get a titer or an index, or an index or a titer is reported by the laboratory. And usually a titer of less than 3 is normal. And when it booked from 3 to 5, it is borderline, and anything above 5 is clearly abnormal. Awesome. And of course, those numbers can vary depending upon the laboratory that you are getting the ELISA testing done. The ELISA test is associated with a lot of false positive titers. So the gold standard today is what is called as a cell-based assay, which is what I described as the first test that von der Leyen did when she created, when she looked at this, where you transfect a Chinese hamster ovary cell line with this with the gene for aquaporin, and it is expressing on the surface of the cell. And if you take the cell and treat it with the patient's serum, wash it, and then treat it with anti-human IgG coupled to fluorescein, and look under the fluorescein microscope, and these beautifully fluorescent cells light up, telling you that this patient's serum has attached to the surface of the cell, and therefore they have antibodies to aquaporin 4. So the cell-based assay is really the gold standard today
Absolutely. Absolutely. And actually, I've had several patients who have gotten the ELISA testing maybe at another clinic, and then we came and did that other cell-based assay, and it actually was positive,
Yeah.
and they were previously thought to be negative. So let's talk about what is neuromyelitis optica spectrum disorder, right? So in the beginning, it was thought that you had to have the optic neuritis, right, the vision problem, plus the damage to the spinal cord to have Divix disease or NMO, and we all had many people that we were seeing who maybe had the bad vision changes, but no problems with the spine, or the long spine issues, no problems with the vision, and they didn't quite fit that criteria, even though we suspected, so the kind of term spectrum disorder really allowed us to, put people under this umbrella of NMO, who we often suspected, and to be able to treat them appropriately, even though they didn't quite fit the criteria of having both of those things at the same time. And then also, once you add in that some people had lesions in their brain, right? And even had, what we call brain syndromes, with certain symptoms related to brain symptoms, that really kind of broadened our ability to diagnose and treat people appropriately. Talk a little bit about that.
So just like you said, spectrum disorder allows us to use this diagnosis beyond just the optic neuritis with transverse myelitis. You can have somebody with just optic neuritis and an aquaporin antibody that is positive, and that person is a spectrum disorder individual, even though he or she does not fulfill criteria for so-called Devix syndrome because they did not have the transverse myelitis. And the opposite is also true. Somebody who comes to you with longitudinally extensive transverse myelitis, and you do an aquaporin 4 and you find the antibody is positive, but they've never had the optic neuritis or anything else. This is just the transverse myelitis, but the biomarker is positive. So these are people that do not fully comply with the old criteria, but they do fulfill the diagnosis with the new criteria. Now, there can be somebody who is not aquaporin 4 positive, but has typical clinical presentation of optic neuritis and longitudinally extensive transverse myelitis, but is truly serologically negative. And that happens. And those are the seronegative NMOSD disorders. And we believe that those are really the same disorder, except probably a different antibody that is yet to be identified. Probably the best analogy that I can give for that is myasthenia gravis, where in myasthenia gravis, we have, like the aquaporin 4 antibody, another antibody that's a marker that diagnoses that disorder. So that is acetylcholine receptor antibody. So basically, that assay improved, and finally about 80% of patients with myasthenia gravis was positive. But there was still 1 out of 5 that most clinicians would believe is myasthenia and fulfills the criteria for myasthenia. Even electrically, they have the decrement that you see with myasthenia, yet they're antibody negative. And then a whole host of other antibodies were discovered for the neuromuscular junction.
Right.
And I'm sure that we will expand our repertoire of antibodies from aquaporin 4. And along the same lines, as you know, the MOG antibody syndrome has now evolved. And the MOG antibody syndrome is another antibody that is associated with lesions in the brain and optic nerve, recurrent optic neuritis, that is sometimes confused as NMOSD. But when you check those people for MOG antibody, they're positive. They're not aquaporin positive, but they're MOG antibody positive. You very seldom see somebody who's positive for aquaporin and MOG. Usually it's either or, it's not usually the two together. So I think over time, we will identify other antibodies that will identify the rest of the group of people. So you mentioned brain abnormalities. There's clearly a type of an NMOSD that occurs, what is called as the diencephalic syndrome, where temperature maintenance can be affected. And I had a patient with that who ultimately eventually passed away with complete inability to maintain body temperature. And this patient would come into the hospital with severe hypothermia, and we would warm the patient up and they'll become conscious and awake again, and they simply could not maintain the body temperature. That's the diencephalic syndrome. Then there is the area postrema syndrome, which is associated with hiccups and intractable vomiting. I had a patient a couple of years ago that came to me after gallbladder resection, and this patient had no reason to go through a gallbladder resection, but they were convinced that the gallbladder was the problem. There was nothing wrong with the gallbladder. It had nothing to do with the disorder, but the patient underwent gallbladder resection, and somebody down the road said, hey, this is neurological, and they got the antibody and it was positive. The area postrema syndrome is a very well-defined entity. They can have intractable hiccups or intractable vomiting, and that's another one of these conditions. So diencephalic syndrome, there is cerebral form where you can have large lesions that occur that actually can look like ADEM, acute disseminated encephalomyelitis. So there is a whole spectrum of disorders that occur, and that's why we use the term SD after neuromyelitis
spectrum disorder. Yeah. I mean, so the understanding has really evolved, and it's been really amazing to kind of watch it unfold over time. And I think one of the things that I've been most excited about is that we now have approved treatments, right? So this is a big deal. Now we have been treating NMOSD with medications that we use for other conditions. We've been using mostly medicines that suppress the immune system in a variety of ways. Although the neurologists aren't as courageous as our oncology colleagues or our rheumatology colleagues, we don't give as high doses as they do for some of their other autoimmune conditions. But we have been using certain medications to try to suppress the immune response. And we don't typically use our MS drugs because some of our MS drugs actually can make NMOSD worse. Can you talk a little bit about that?
Oh, absolutely. In the early days before the antibody was available, we made that mistake far too many times, where the patient was thought to have, MS, but really had, in fact, the old days, it was very common for somebody to go that route rather than directly the diagnosis of NMOSD. They can get treated with the MS medications, and almost all of the MS medications can make you worse rather than better. The exception, of course, is ocrelizumab, which is one of the treatments that we use for MS, can work for both MS as well as neuromyelitis optica spectrum disorder, because they're both, the anti-B cell therapy are very helpful in blocking what happens in patients with NMOSD. So, but almost all the other treatments can make, NMOSD worse. And it's very important to make this distinction of, is it MS or is it neuromyelitis optica? One of the things, a few years ago, we had a symposium on neurological disorders and pregnancy, and we discussed this patient, a young lady who had recurrent optic neuritis that everybody was going down the path of. She was called CIS, clinically isolated syndrome. Everybody was waiting for her to evolve into MS. And in the meantime, she said, can I get pregnant? And she said, yeah, go ahead. People do well with pregnancy and MS. Well, this lady took a nosedive and was on a ventilator for 9 months of her pregnancy. And so this is something that is very important to recognize the differences. Patients with MS do well with pregnancy. Patients with NMO can do worse, and they don't have to, but they can do worse. So that distinction is very important, not only from the standpoint of what treatment do you use, but also what you advise regarding a number of other things, including pregnancy.
So we now have 3 FDA-approved treatments for NMOSD, which I think is amazing.
What is amazing is all 3 came to us the same year.
In the same year. I mean, it's like,
from nothing
it's like
to 3.
we go from nothing to 3, and that's kind of how MS is also. We'll have a period where nothing's going on, and then we might get 2, 3 new treatments a year, and then the year after that, the year after, so it's been really fascinating, that now we have treatment options. I think one of the limitations, though, is people do have to be have a positive antibody, to qualify for many of these treatments. And so in some cases, there can still be limited access for some patients because if you don't have that positive antibody, you don't, and that doesn't mean we don't treat you. We still have our other treatments that we were using before, but we can't use the FDA approved ones if we don't have that positive antibody test. So again, very important to diagnose early, and to get the cell-based assay test so that we can make sure we're getting an accurate diagnosis. So,
That's a very important point that if somebody is negative, you don't stop testing because
right.
they can become positive.
Absolutely.
Yeah.
Absolutely. So, this is a really fascinating topic to me. But before we kind of wrap up, I want to talk a little bit about you got so much amazing work going on. I want to talk a little bit about tell us a little bit about the NARCRIMS registry.
So NARCRIMS is an acronym that stands for North American Registry for Care and Research in Multiple Sclerosis. And this is something that I had wanted to do for the longest time because I think that you get incredible amount of information from every single patient you treat. You learn so much. There is no substitute for experience. And basically, every patient teaches you something. And that said, you can't learn everything about a disease from an N of 1. You need to have the 30,000-foot view to look from above when you start to see patterns emerge that teach you about the nuances about the diagnosis that you did not recognize when you saw one patient at a time. For example, we used a drug called mitoxantrone that was a wonderful drug. And I remember when I was at Ohio State University and I had a patient, the patient developed acute promyelocytic leukemia. And I never associated it with the treatment that I was giving him until I had a second patient and a third patient. And then I knew there was something wrong here. And we all of a sudden put that out as an abstract for the American Academy of Neurology. And somebody else walks up to me and say, hey, that's interesting that you have, patients on mitoxantrone that is having this problem. I treated and got the same issue with one of my patients, but I had no idea that the two may be connected. And that is something that you learn when you look at it from above. A 30,000-foot view will now suddenly start to see patterns that when you use this drug, not only do you get leukemia, but you get one type of leukemia, acute promyelocytic leukemia, which has got a specific translocation of the chromosome that occurs. And so, you need to look at not one patient, but a group of people to understand that's the case. Another thing that was clear was, when Christian Confavreau looked at his population of patients in the EDMUS registry in France, he noticed that the pregnancy was associated with a good outcome, and before that, people used to say, don't get pregnant. Your MS can get worse, and so when you started looking at large numbers, patterns emerged that told you, no, that's not correct. There is a pattern here that actually patients with MS during pregnancy do reasonably well. And so that became apparent from his registry. And then he made a very interesting observation that if you look at people whose disability reached about 4, EDSS of 4, that change from 4 to 6 occurs at the same rate for everybody. In other words, it may have taken one patient 20 years from diagnosis to get to 4, and another patient 10 years to get from the diagnosis of normal to 4. And so both these people took a certain time to get to the 4, but when you follow them from 4 to 6, meaning the time to require unilateral assistance was the same for everybody. And that observation was mind-boggling. Nobody had known that till he published it. And then, of course, it has impact on clinical trials that,
Mhm.
if you put somebody on 4, more likely than not, they will go to 6, not because of your treatment failure, but because that's the nature of the beast. I
That's the
call it
nature.
the roller coaster effect, where
Right.
it can chug along, chug along, chug along to the top, but the time it takes from the top to the bottom after that is the same.
It's the
And
same.
and that came from the registry. So I had wanted to start a registry for MS for the longest time because I thought it
Mhm.
was very important. We didn't have a registry in North America, and I thought that was crazy. We have
Mhm.
so many patients, the largest span of geography compared to Europe, where we can actually look at it. So I went to the MS Society when I was chairing the clinical advisory board, and everybody, we put our heads together and said, "Yep, this is a good thing," but nobody could figure out how to fund it. It was a very difficult. It was such an expensive item, so it died a natural death until
Mhm.
somebody brought to my attention this thing called ADNI, which is Alzheimer's Disease Neuroimaging Initiative, that actually was funded by pharma. Every pharma put a pot of money, and that pot of money created this database from which
Mhm.
so much information for Alzheimer's
Right.
came. So I went to the pharma and said, would you guys be willing to put some money to start a database that will tell us the natural history of the disease? And
Right.
everybody said, what a great idea. So
Mhm.
every single pharma that has an MS product put out money, and it went to the consortium, and we put together this registry that is coast to coast and in between.
Mhm.
26 sites, 1,000 patients. Today we are at 958. So
Mhm.
we are very close to the 1,000 mark.
Show 1,000.
And yeah, and so we would really, we hope that this registry will teach us everything we want to know about the natural history of the disease, and understand, you know, all the nuances of MS that a single patient cannot teach you, but a
Right.
group of people can teach you. So that,
Absolutely.
in a nutshell, is NARCRIMS. So
Yeah.
each site has about 50 patients. We have about
Mhm.
26 sites. There are 5 sites in Canada, so it's North American in scope.
Mhm.
And I'm sure that registry will outlive you and me and everybody on this
Yeah.
call, unless MS is wiped out from this earth. Which,
If we cure it, hey, I'd be happy to
hey,
cure people and send them home. Listen,
it
I'd
is
be
going to
happy.
happen. It is going to
Yeah.
happen. It will happen. No
It
two ways
will
about it.
happen. It
Yeah,
definitely is gonna happen.
it's going to
And so
grow.
I think that's so amazing, because in most other countries, they do have national registries. So we do not,
Exactly. Yeah,
obviously the US, we are a different breed. We like our privacy, we don't like anybody forcing us to do things. But much of the data that we had, especially when COVID came around, came from countries initially that had those registries where there was information about everybody with that condition, and it really helped us to better understand. So this is really important to have something that's nationwide, because there are many registries in different parts of the country. There's some in New York, some over here, those types of things. But just to have something that's nationwide so we can learn about the course of
that's
MS
true.
is extremely important.
Yep.
Extremely important. All right, so I digress. We are coming to the end of our time. We could sit and talk about this for another 45 minutes, but listen, I don't want to get in no trouble. They give me an hour, so I don't want to get in any trouble. But I thank you so much for your time and your insight, and the amazing information about NMO. What are kind of some parting thoughts that you would say, for people who are recently diagnosed with NMOSD, or who may be in the process of possibly being diagnosed?
So the outlook is so different today compared to, even 10 or 15 years ago when we had nothing. And we have very, very effective therapies for NMOSD. If you look at the eculizumab trial, the adjudicated relapses were a handful. I mean, these
Mhm.
people went, and we have people that have been on the drug for 3 years, and before that was in and out of the hospital. And this patient is in a clinical trial, and she told me, Dr. Rammohan, you know, my daughter and I were talking about how this is the longest I have been without going into the hospital. That was so
Wow.
great to hear that. And so the outlook is so much better. And another thing that is very important to distinguish this disease, neuromyelitis optica spectrum disorder, from multiple sclerosis is in MS, we have a huge problem of two types of issues. One is the relapse, and the other is the progression. And the progression and the relapse are two distinct entities, not necessarily linked with one another, except to the fact that relapse related progression can occur. But even if I completely blocked relapses, I still have to deal with this underlying progression,
Right.
which is not the case in NMOSD. All of the disability that occurs in NMOSD is relapse related. There is no such thing as progressive neuromyelitis optica. There is simply not that entity. There is no progressive form of optic neuritis. There is no progressive form of myelitis. It is all the disability that a patient with NMOSD goes through is relapse related. And if I can block 100% of the relapse, I've blocked 100% of the disability. And
Yeah.
that's huge. That's huge. And
Yeah.
I think we are finding agents that are super duper good, that I think you can have a world of NMOSD with no disability.
Yeah. Yeah. Amazing. And I cannot sum it up any better than that. Um, Again, I don't see any questions in the chat, but thank you so much for this amazing discussion, for this history lesson. I mean, I'm over here taking notes. I hope everybody else is taking notes. And I thank everyone for tuning in and taking your time out on this Monday night to talk about neuromyelitis optica spectrum disorder with my esteemed colleague and expert, Dr. Kottil Rammohan. So thank you, everybody. Don't forget to subscribe to our podcast, Brain Chat with the Nerdy Neurologist, on all podcast platforms, Spotify, Apple Podcasts, etc. And share the show with a friend. We'll be on YouTube for blackdoctor.org and for Dr. Mitzi Joy MD. Thank you guys so much and have a wonderful night.
Thank you. Thank you for having me.
Absolutely.